Sunilji, we are live.
We are live.
Okay. Good evening, everyone. Welcome to iFocus Online, Lecture 162 and Retina Session 14. Today we have with us Dr. Subhadra Jalali, Dr. Parveen Sen, and Dr. Deepika, and they'll be taking the Retina ERG Part 2, that is Interpretation, Multifocal ERG, and a short electrophysiology quiz too. Over to Dr. Ritesh, sir, to please introduce the speakers for the day. Ritesh, sir, you're on mute, sir.
Thank you. Thank you, Dr. Rolika, and good evening to all of you. It's indeed my pleasure to introduce my teacher, Dr. Subhadra Jalali ma'am. Though she needs no introduction, she is well-renowned figure from India to all the way across the world as a landmark person in the field of retinopathy of prematurity, and her other field of interest being hereditary retinal degenerations. And ma'am needs no introduction. I'm really happy to see ma'am here and like really looking forward to learn a lot from her today. Along with ma'am, we have Dr. Parveen Sen, another teacher whom I've had a chance to learn from in multiple conferences. Ma'am is a senior consultant at Shankar Netralaya. As far as I know, ma'am, she is also strongly interested in pediatric retinal surgeries and managing pediatric retinal disorders. So for this particular session and topic, I'm really happy to see Subhadra ma'am and Parveen ma'am here to teach us, and it is going to be a great learning for all of us. And along with them, we have Dr. Deepika CP. She's a consultant at Hyderabad. And also she is the upcoming person who is taking charge from Subhadra ma'am and has shown a lot of interest in inherited retinal diseases and imaging and electrophysiology. So we are really happy to have our three speakers here today, and I think we'll be starting with the first session. I request Dr. Subhadra ma'am to please start her first talk. Thank you.
Thanks, Ritesh, and thank you everyone for being here. So we will have 4 sessions in this. So my first talk, I'm just swapping the order, and I will first speak on ERG in vascular retinopathies. So I hope you can see the slides. Okay. So far, most of the talks that we've had is on retinal dystrophies, and people think that ERG is only for retinal dystrophies, but it, as I had told yesterday before, that ERG and all this electrophysiology actually tells the function of all the cells in the retina and the optic nerve. So it is useful for studying the function in any disorder. So let us look at the vascular retinopathies and ERG. So we are mostly going to focus on these 4 entities, that is ocular-speak syndrome, retinal vein occlusion, arterial occlusion, and diabetic retinopathy. Of course, the toxic vascular effects are also there, which I'm not going to go into details here, which also affect the vascular supply and they affect the electrophysiology outcome. Now, the basic understanding why we are able to use visual electrophysiology for various vascular diseases is that the outer retina, that is the photoreceptors, they are supplied by the choroidal vessels. So any disease which affects the A wave, the photoreceptors, we can study. On the other hand, the inner retina, that is the bipolar and the amacrine cells, they are supplied by the central retinal artery, which you know is in this layer, and the branches of the central retinal artery. So it will be lost in those conditions where the inner retina is affected. So because of this dual blood supply, our electrophysiology will show either damage to the photoreceptors, which means the A wave will be affected, or damage to the inner retina, which means that only the B wave will be affected. Of course, the B wave will be affected only if the photoreceptors were normal, and we can study that the A wave was normal, but the B wave is absent. So obviously, in cases with inner retinal ischemia, which is what we are interested in, the deep retinal ischemia, the B by A wave ratio will change. The oscillatory potentials uniquely come from the inner retina. So whenever there's an inner retinal ischemia, these will change. And same way, the flicker retinal response, because it is from the own cells, which are the highly visual acuity transmitting cells, they will get affected in the inner retinal ischemia. Whereas the A wave will be lost in the outer retinal ischemic conditions, mostly the choroidal vascular disorders. So is there ischemia? Is one question which the electrophysiology answers very well. It has 100% sensitivity for us to know whether some ischemia is there or not, especially a widespread ischemia. For example, even in diabetic retinopathy, even before there is retinopathy, seen, patients of diabetes can have abnormal ERG in their eyes, and a lot of work has been done on ERG in diabetic patients. So it is thought that in the initial phases, it is mostly a metabolic effect on the neurosensory retina, but it has been found that the moment an NPDR converts to a PDR or an NBD is going to develop, then the oscillatory potentials are markedly reduced. You can see here the oscillatory potentials are markedly reduced. The flicker also starts changing. So really, like, FFA is an invasive test. You don't want to do FFA, you can do an ERG. Now, generally, we don't do this for diabetic patients because now we have excellent other imaging modalities, non-invasive like OCT, angio, or even fundus photography. But this is just to know that if a patient has diabetes, their electrophysiology will change. I used it only for one patient who was a diabetic patient, and he had cataract surgery in his only eye in childhood, and the pupil was very small after congenital cataract surgery. And we really could not look at the fundus. So I followed him up for next 5 to 7 years just on electrophysiology, and his electrophysiology was totally normal. So we could imagine that he doesn't have any significant retinopathy. After 6 years, we got a little nervous because we really didn't have too much experience. So then we did a pupilloplasty, which he was not willing initially. And then we could look at the retina, and really he had no retinopathy in that eye, and our electrophysiology was telling us the truth. So as far as the retinal vein occlusion is concerned, I think that is one area where every central retinal vein occlusion, I like to do electrophysiology. The reason for this is that it is non-invasive. It detects inner retinal ischemia, which is not detected by FFA and very limited by OCT angiography. It doesn't have a limitation of the field of view. You can know about the retina right up to the periphery. It is not limited by media opacity, which many of these patients could have, like cataract or hemorrhages or PCO. And it is not affected by the retinal hemorrhages and edema, which would, camouflage the underlying capillary non-perfusion. And of course, it can be done in patients who have systemic comorbidities. In fact, electrophysiology ischemic changes along with RAPD has 100% positive predictive value for neovascularization in CRVO. And I almost always, all my patients of CRVO undergo electrophysiology to know whether it is ischemic or non-ischemic, and whether after the anti-VEGFs, do I need to do a laser or I don't need to do a laser. So here is just to show that, there are a lot of hemorrhages. It looks like a very bad CRVO, but we can see that, in that eye, the oscillatory potentials are good. The B wave is very good. The flicker response is very nice. So it is telling us that this is a non-ischemic CRVO. So when we look at the implicit time of the flicker, you can see here, it says 33.6 milliseconds in the right eye and 27.8 in the left eye. If the flicker implicit time is more than 37 or the intraocular difference is more than 7, then it tells us that this is ischemic. Otherwise, it is non-ischemic. So here we have another patient who has hardly any hemorrhages. Retina doesn't look that bad. Of course, the FFA is showing that there's extensive non-perfusion. And look at what is happening to the flicker. It is showing that there is absolute haywire of the flicker ERG. It is very much prolonged to more than 37. It is 47.6 milliseconds. And you can see here that the B wave is markedly reduced. The A wave is only a little reduced. So all these things tell us that there's extensive ischemia in this patient, and we need not have done an FFA in this patient to know whether it is ischemic or non-ischemic. So same thing, we can see here that the oscillatory potential is not very bad. The flicker is little bad. So this is telling us that, there is an ischemic CRVO, even though the FFA doesn't show that widespread capillary non-perfusion. So this I had shown last time also, both eyes bilateral CRVO, and the patient needs to know that, his right eye is ischemic and left eye is non-ischemic, because the flicker ERG is very good in the left eye, it is bad in the right eye. So if both the eyes are involved, then we look at the intraocular difference. And you can see here the oscillatory potentials are absent. This is just the 60 megahertz line, that is the electrical noise which is coming, which is like, repetitive noise. And these are the true oscillatory potentials. So now in BRVO, branch retinal vein occlusion, usually we don't do electrophysiology because only a quadrant is involved and the flash ERG will not be affected. But here is a patient who has had an old BRVO and laser marks, and he had 6/6 vision, and now he gets a fresh macular BRVO. And now he's very worried because his vision has gone down and he wants to know, will my vision improve or not? And we do a multifocal ERG, which shows that the foveal responses under that hemorrhage are very good. If we did FFA, it would only show a blocked fluorescence, and we don't know the function of the underlying retina. You can see he had a ischemic BRB here. Now we don't know whether there is ischemia here or not. There is a soft exudate, there is some occluded vessel, but the multifocal ERG is showing very good response under that hemorrhage. And yes, we could predict, and it happened that as soon as the hemorrhage is resolved after 6 to 8 weeks, he got back 20/20 vision in that eye. So in ocular-ischemic syndrome, there is no other test which is as good as the electrophysiology. As I said, you will immediately know that there is a ocular ischemia because of the bad oscillatory potentials and the delayed flicker. So here we have a diabetic patient who is having new vessels in the retina, but you see there is no NPDR and there is no retinal vein occlusion. So if you have new vessels or hemorrhages in the retina, whether it's diabetic or non-diabetic, then ocular-ischemic syndrome is high on priority. The carotid Doppler, which mostly in our country is done as an external carotid Doppler study, may not show us the actual ocular ischemia lesion because it could be intracranial, and there are hardly any labs which do transcranial or intracranial Doppler in our country. So really the electrophysiology tells you that there is ocular ischemia. And this is illustrated by this patient. You can see here patient was having diabetic retinopathy, referred to us before cataract surgery, vision is 20/50. But there were two things on fundus examination which made me think that this is not diabetic retinopathy. Because in diabetic retinopathy 1, you would find a lot of NPDR. If you had CSME, like if we thought that this is CSME, you would have a lot of microenzymes and hemorrhages. But here you see the whole retina is bald looking. That is, there's nothing, no hemorrhages, no microenzymes. And the other thing was this sausage-shaped vein. You can see this vein is very dilated and sausage-shaped, which is not there for the other veins. So this made me think that this is not a simple NPDR, but this has an ocular ischemia. And when we did ERG, it did show that there was significant ocular ischemia. There were no oscillatory potentials in both the eyes. So we warned the cataract surgeon that after surgery, this patient needs close follow-up for NVI, NVA, because ocular ischemic eyes after cataract surgery can develop neovascular glaucoma. But they didn't believe us. They said this is mild NPDR and everything is good. And 6 weeks after surgery, patient comes to emergency with hypopyon, fibrin. She was diagnosed as endophthalmitis, vitreous biopsy IOB was done. After 4 days, she comes with frank neovascular glaucoma, 50 pressure, and returned back to us, and we knew what is happening. And meanwhile, her other eye, which also showed ocular ischemia on ERG, because we followed her up every day, every week for NVI, she developed NVI in follow-up. We did laser, and then post that, she had cataract surgery and 20/20 vision and no neovascular glaucoma. So that is the importance of the clinical findings, looking at every finding properly and not just, a very cursory fundus examination. This would have been labeled as NPDR. It is not. So in arterial occlusions, usually because if the retinal artery is occluded, the B wave will go away and there'll be a normal A wave because photoreceptors are healthy. So we'll get a negative ERG, which I will just show. Whereas if there's an ophthalmic artery occlusion, then both will be absent. So this is something which is sometimes asked in your exam. What is the difference between central retinal artery and ophthalmic artery occlusions? If you have a CRAO case, and you should be able to tell all the differences, and one of the differences is on ERG. And this is very logical. So here we can see a cherry red spot, and what will happen to the electrophysiology is that the pattern ERG and the isolated rod response will be absent. But the classic thing that you see is that the photoreceptor function, that is A wave, is normal, and there is no B wave. This is called as a negative ERG. Negative means we are having a negative wave, but we are not having a positive wave. And you can see here the oscillatory potentials are bad and the flicker response is also bad. So, but usually we don't do electrophysiology for acute CRAO because it is a clinical diagnosis. You can make it out by the cherry red spot and the RAPD and the sudden loss of vision. But there are cases where, patient has had old CRAO and we are not able to diagnose. I will just show two patients. Before that, I will just show some of the causes of this negative ERG. So whenever you see negative ERG, which means the A wave is present and B wave is absent, it's an inner retinal disease, not only central retinal artery occlusion or ischemia, but there are a whole of other conditions which will cause the same ERG. So we should, on ERG, we should not say this is CRAO, we should say this is a negative ERG and then try to find out the cause. So let us see a clinical scenario where a patient has come to us and she had lost vision during her last pregnancy, and this is what she presented with in her left eye with poor vision. And she was referred as chorioretinitis or healed choroiditis. But you can see here that she had some RP changes and the disc was very pale. So the question was that did she have optic atrophy and choroiditis, or did she have something else? So when we did the ERG, it is showing a very nice A wave and an absent B wave. So that is telling us these are all manifestation of pregnancy-induced hypertension lesions which cause optic neuropathy and choroidopathy. So these are manifestations of PIH, where there was an exudative detachment, and once the retina reattaches, it causes this choroidopathy, it causes an optic neuropathy, and these arterial narrowing, silver wiring, they are part of the hypertensive retinopathy part. So this is what tells us that this is not choroiditis and optic nerve disease, but this is disc pallor secondary to a retinal artery occlusion during the PIH episode. Here's another patient. So patient says 54 years old. 2 months ago, he had sudden loss of vision and now he's recovered, but he's not happy with his vision. On examination, vision is pretty good. It is 20/25 N8 and there's an ill-sustained pupil. So patient was referred as retrobulbar neuritis. You can see little disc pallor. That this is a patient who had retrobulbar neuritis and it has recovered. So how do we differentiate that, yes, this is truly retrobulbar neuritis? If we do VP, it will show. Whenever you have a patient who has poor vision, complaints, but the vision is very good, 20/20, 20/25, you must do a field, because 20/25 vision patient will not be unhappy with the vision. But you can see here has extensive field loss, dense in the center and peripapillary, and really it's not matching a typical optic neuritis scotoma, which would be a central scotoma or a centrocecal scotoma. So going further, if we do VP, so these are the normal we see here, and this is the right eye of the patient, and we can see here in the left eye the VP is absent. So again, we will think that this is optic neuritis or retrobulbar neuritis healed or resolving or whatever. But as we had said in the previous lecture, always VP should be added only after you do a flash ERG, because we want to look at the health of the retina also. So here we see that in the case, the scotopic ERG, flash ERG was normal. The oscillatory potentials were pretty good. The photopic was little low in the affected eye, whereas it was normal in the other eye. And we see that the pattern ERG was absolutely flat. Now, if it was just optic neuritis, then the pattern ERG P50 should have been normal. That is, the photoreceptors in the macula should be normal. But here we are seeing that the photoreceptors are bad, and also the flicker response, that is the cone response from rest of the retina, is also bad. That means that there has been a generalized retinal insult and also a macular retinal insult in this patient with disc pallor, and this is not just a optic neuritis. You can see that on OCT, the macula was affected and the foveal contour is gone, and there's a thinning of the layers of the retina. So what this patient actually had was a transient central retinal artery obstruction. So the classic cherry red spot will come and the classic negative ERG will come only when the vascular occlusion or the retinal artery occlusion has been more than 4 to 6 hours. But if it was transient, you will just see little clouding during the acute phase. And immediately after that, in few weeks and months and even hours, the whole clouding will go away because the embolus has passed away, and you will be left with a disc pallor, which you might confuse with an optic nerve disorder. So just to highlight this case again, that in this case with a disc pallor, who presented with this type of retina, if had we seen him in the acute phase, this is what we would have seen. But he didn't report in the acute phase, he came in this phase. But our electrophysiology is telling the whole story that this is not an optic nerve disease, but this is a retinal artery occlusion. Obviously, the management and the plan of action for this patient would be a cardiovascular risk assessment and not an MRI. So I want to just close by saying that in vision loss of unknown origin or just disc pallor, we need to do a combination of tests to know where is the defect. And the flash ERG is an extremely valuable, non-invasive, very sensitive test to do whenever we are looking at the vascular supply to the inner retina. So I will close here, and if there are any questions, we'll be happy to take.
Thank you, ma'am. That was quite an interesting discussion. Do we have any questions as of now? I'm not getting any questions at the moment, ma'am.
Okay.
We don't have any questions.
I think we'll go to Praveen Sen's talk then.
Can I just add a point here, ma'am?
Meanwhile,
highlighted one of your cases. I remember very recently a patient who presented with neovascular glaucoma, and the fundus looked absolutely just a few dot plot peripheral hemorrhages, but nothing else which could explain. the patient was not getting a clearance for fluorescein angiography from his nephrologist. And the electrophysiology was the one which actually made us help document loss of perfusion and monocular ischemia, and on basis of which we could actually convince the patient that this needs further treatment. Otherwise, he was just being labeled as mild NPDR, though iris had started showing neovascularization. So in NVG, it is a very useful tool wherever, or in any vascular condition, wherever in doubt. Sadly, the only functional test available is the least used, actually, ma'am.
Yes, yes. I think the knowledge and the information that electrophysiology will tell you what no other test will tell you. And it directs directly to the treatment the patient is needed to undergo. And it can also be life-saving, because if you detect that he has ocular ischemia and you then order for both the transcranial Doppler and the external carotid Doppler or an MR angio, then it will pick up a life-threatening condition of the carotid artery system or other vascular system of the brain. You can save the life of the patient.
Right. Thank you, ma'am. I think let's move on to the next talk, ma'am. Dr. Praveen, ma'am.
Yeah, thank you, Ritesh, and good evening to all my students and friends who are here. And thank you, Dr. Subhadra, for making me a part of this learning experience. So after a very good and talk by Dr. Subhadra ma'am, we will go on to a little less known form of ERG, which is the multifocal ERG. So basically, this was originally developed by Sutter and Tran, and it is important because we all know that full field ERG gives us the response from the whole of retina, and multifocal ERG simultaneously records responses from many focal areas of the retina, and with that gives us a topographical array of little or small ERGs. So if you see the difference, both full-field ERG and multifocal ERG, it is important to remember that full-field ERG is recorded both in the dark-adapted and the light-adapted conditions. So it gives you the function of both rods and cones, as compared to multifocal ERG, which is always recorded in the light-adapted condition. So it's largely a cone-driven response. So it gives the electrical activity of the entire retina, that is full field ERG, and simultaneous measurements of small multiple retinal foci, and responses from these foci is multifocal ERG. So ERG, full field ERG is actually a true electrical response, but multifocal ERG is a mathematical extraction which is done by the computer, or which is done automatically by the system. So that is what you get. And full field ERG gives you the entire retinal response, and multifocal ERG gives you only the central 40 to 50 degree of the retina. With this we come to the typical kind of a setup which is there for multifocal ERG. So pupillary dilatation is required, light adapted condition, almost normal ambient room illumination is what we use for multifocal ERG. About 61 to 103 hexagon setting stimulus is what is recognized by ICEF as a standard. You can go less or more, but the ICEF recommends standard as a 61 to 103. Monocular recording is usually done. Refractive error correction should be in place. And this shows you the electrode which is used, the stimulus which is used, and how it is interpreted. I will go to these things in detail one by one. And most important, paramount importance in multifocal ERG is fixation. So if there is a patient who does not have a good vision and cannot fixate, multifocal ERG is usually not dependable in this kind of a patient. Stable fixation is of utmost importance. That is why in every stimulus of multifocal ERG, you will have a central fixation dot or cross or circle. In fact, it is so important to have the central fixation that the central fixation dot also is made small. It should not cover the entire central hexagon, because if it does, it will reduce the stimulus from the central hexagon, and that too will interfere with your interpretation. So when you do the recording should always have the patient should be refractively corrected. And there is a knob at the multifocal ERG system or the stand itself, which can be used for this optical correction. But if the patient is using glasses, we could give him glasses or you could do the child frame and put his lenses in place as well. But you must understand that if you are using a high myopic lens, then there will be something like a rim effect will be present, and that has to be taken care of. Also, high myop will result in minification of the image size. So the response will be different in these patients. So next time when you do multifocal ERG of the same patient, you must remember to use the same refractive error in place, only then these responses will be comparable. This is the typical stimulus which is used. It is called the pseudo-random stimulus, but there is nothing random about it, which is why it is pseudo-random, because these hexagons light up or become dark following a particular sequence, which is called the M sequence. It appears to be random, but is not really truly random. At a particular period of time, there's a 50% chance that each stimulus or each hexagon may be bright or it may be dark. And another important thing, if you notice, the central hexagons are generally smaller in size. As you go towards the periphery, they become larger. And this is to take care of the cone density. So the cone density is very high in the central area. So the hexagons are smaller. So this makes sure that each hexagon excites the same number of cones. So this is what I was talking about. You could have a 37 hexagon stimulus. This is a 61 hexagon stimulus response. This is a 103 hexagon stimulus response and 241 hexagon stimulus response. So what is the difference between these things? So just to give you an example between a 61 and a 103 element response, the duration time for a 61 element is much lesser. For 103, the patient has to cooperate for a longer period of time since the recording time becomes more. But 61 hexagon gives you a better signal to noise ratio because the amplitude that you get from 61 elements is larger because the hexagons now are larger. But when you see the 103 element, because the amplitudes are smaller, so then there is low signal to noise ratio, and easily if your impedance is not good, it can interfere with the response. Spatial resolution is much better in cases of 103 elements, much less in cases of 61. And in 61, it may be sometimes difficult to monitor fixation as the location of the blind spot may be difficult to identify. Here, because it is covering a larger area, so you can have easily locate the blind spot, and this helps you monitor the fixation. So there is usually a compromise between the recording time and the resolution between 61 to 103. Wherever resolution is important, better is to go with the 103 element hexagon. Another way of analysis is the trace array, and this is very important that in the multifocal response, when you get individual responses, you can have this in form of a trace array, or you can have ring analysis. So it is divided, these traces are divided into different rings, each one with a different degree of angle that it subtends at the retina. So R1 is 1.6 degree, R2 is 1.6 degree to 6 degree, R3 is 6 degree to 11.4. You may not remember this, but you can remember this when especially you are looking for HCQ toxicity. You will realize that the central ring may be spared, yet the perifoveal and the parafoveal rings are more commonly affected. So this gives you the distribution of disease, which is a very important function of multifocal ERG. So topographical error, this is very useful because even the person who cannot interpret can immediately look at it and tell you the distribution. You know here that the central foveal response is good, and the peripheral response is lesser, but it can be a major pitfall as well, because even in the absence of a good trans array, if you interpret this, sometimes you may end up in a faulty interpretation. So this is because you must understand that these topographical analysis are made based upon the changes in the amplitude. So they definitely are not giving us any information where the latency or the implicit times are concerned. And you can have large or abnormal delayed responses and still have normal 3D plots, because 3D plots only take into consideration the amplitudes. So sometimes you can even, the noise itself can give you the central peak without it being a true response from the retina. So the origin, there is still a lot of controversy on the exact origin, but for your understanding, you can remember that this is N1 wave is almost something like the A wave, and the positive wave here is something like the B wave, though largely driven by the cone bipolar cells, but they are not exactly similar. So they are not called A and the B waves. They are called the N1 and the P1 waves. So kernel responses, just a word about it, that this is, as I mentioned briefly before as well, that these are not the true response, but a mathematical response. Just to simplify it a little bit, so you can imagine that this hexagon probably was dark in the first, at the first time when the analysis was being done, and this second was white. So now there's a chance that you could have the second stimulus as white. So whether the white falls on dark or the white falls on white, so mathematical extraction of the responses will be different. Again, the black falls on black or the black falls on the white, the mathematical response will be different. So the first kernel order responses are mathematically extracted by adding all the responses following a white presentation and subtracting all the records followed by a black hexagon. So luckily or fortunately, we do not have to do this manually, and this is done by the system and given to us. But for the understanding, you must need to know that this is not a direct electrical response, but it is an extraction. Again, there is something called the second order kernel as well, because whether the first response is positive or negative, and whether it is of higher amplitude or lower amplitude, will also depend upon whether the white is fallen on the previous, whether the previous stimulation was white or black. So it takes care of the previous adaptation. The reason why we don't have this kind of a second order or this kind of a adaptive responses in full field ERG is because the interstimulus interval, ISI, in full field ERG is significantly long. So the cells can recover in between the two stimuli. But here in multifocal ERG, since the stimuli are very rapid, the cells cannot recover from the previous stimulus which was given, and hence there is an adaptive state which is involved, and this affects the second order kernel responses. They are of limited value as of now because we don't fully understand them. Maybe in future we do find some use for these. So when we do interpretation, things to remember, it's a general rule in all electrophysiological interpretation. When you look at amplitude, you are looking at the quantitative number of functioning cells. So reduced amplitude will mean reduced number of functional cells, interpreting cell death. Delay time to peak or broad waveform will always indicate sick or dysfunctional cells. So change in the amplitude and increase in latency are one way of interpreting. Multifocal ERG has a third very important interpretation, which is spatial variations or topographical loss. So diagnosis is made based on whether the central responses are reduced or whether the peripheral responses are reduced. You can look at it and get some information that here the central retina is not functioning well. Here the peripheral retina is not functioning well. Here there is a generalized reduction, and here there's a localized reduction somewhere inferiorly, but the superior ones are good. So this kind of an information is not given to us by full field ERG, and here multifocal ERG complements the full field ERG. The artifacts, it is very prone to get artifacts, the multifocal ERG. So this is important to understand this. I'll just spend an extra minute on this. So this is something like a normal responses that you are getting from a multifocal ERG. A novice may also think that these are also good responses, but actually if you see, these are not particular waveforms that you are getting. This is just electrical noise from the background 60 Hertz. So this has to be interpreted carefully. When you see these multiple peaks, make sure you don't interpret them as a true MFERG waveform. This you see the fixation, the waveform here is very of high amplitude, while here it is in the center, it is of low amplitude. This cannot be explained by any pathological condition. This is usually eccentric fixation. You must rule out eccentric fixation, ask the patient to fixate, and then see whether it still persists before you interpret this. Positional artifacts. You can see that this here, they are somewhat bigger, and then here they become smaller. So look again, the Retinal electrode that you are using, make sure the cornea is in the center of it. The lenses that you are using to refract, make sure they are covering the whole eye and not just one part of the eye. and the patient is partly seen from outside. With this background, just let us go through a few clinical conditions where multifocal ERG can be useful. So this is an example, similar looking retina on both the sides, tapetal reflex here, but you can see this is almost a generalized reduction on multifocal ERG. Since this is still an early stage of disease, you can see photopic responses are slightly down, but otherwise they're not completely flat. But here on the left-hand side fundus, this one is the multifocal ERG here is very beautifully preserved, very good responses. Only the central area is affected and the ERG is normal. So definitely this is a patient of Cornrod Dystrophy, and here you have a patient with a limited macular dystrophy, something like Stargardt's disease. Again, we all know that this is retinitis pigmentosa, but in future, when we are looking at gene therapy or some other trials, how do we look at the response to therapy? Fulfilled ERG will not give us the response to therapy because it is extinguished. If you do a multifocal ERG and the central island is spared, you can see whether this improves or decreases with your treatment. So this can help you look at the progression of disease. Again, CSCR, this is actually a decade or so ago when the multifocal ERG just started. It was one of the earliest investigations which gave us the information that CSCR is not just a macular disease. It's a generalized reduction of the retina, was first picked up here on multifocal ERG. This is another example of Stargardt's disease where you can see only the central area is affected. And if you see fundus pavimaculatus, which is a more widespread disease, and this can be prognostic because a larger area of the retina is involved, as seen very clearly on multifocal ERG. In drug toxicity is the main utility of multifocal ERG, especially hydroxychloroquine toxicity. This is an example of a patient who is using about 400 milligram per day of HCQ for a year and 200 milligram for 2 years. And you can see early stippling is present here on the retina, and multifocal ERG very nicely picks up the central area, which is down as it is seen here, and full-field ERG remains normal. This is in contrast to chloroquine toxicity, where a much larger area may get involved very early on, and the chloroquine toxicity can happen at much smaller doses as compared to HCQ toxicity. Just a few words about it. You can see that toxicity due to HCQ is extremely important because it is non-treatable and the central vision can be preserved if the damage is known in the early stages and you stop therapy. But again, at the same time, you must understand that HCQ is a very valuable drug, and you should not just stop it with the first sight of suspicion, but definitely document toxicity before you stop it. And these are the new guidelines, and MFARG, FAF, SDOCT definitely form a part of a screening protocol for HCQ toxicity. And these are the major risk factors for patients to have HCQ toxicity, dosage of more than 5.0 milligram per kg weight for definitely more than 5 years, and associated renal disease, which usually will have sometimes, especially in patients with SLE, where renal disease will be coexistent, and they will also be using HCQ for the arthritis, so it can compound the problem. Another example that we have documented as well, desferoxamine toxicity. All this can be easily picked up. Dr. Subhadra very nicely pointed out how full-field ERG can be useful in diabetic retinopathy. Multifocal ERG can be even more useful because it can pick up the posterior pole limited macular changes, and these changes can actually correspond to the area of pathology as well, and you can overlap it and see it. Just to give you an example, this is a normal patient, which you can see good responses. This is with without DR itself, the responses have started falling down. And this is with early DR and late DR, it's absolutely like a squiggle. In fact, we have recently finished a study and it is under review, the paper which we have seen that when we have seen OCTA has shown us that you can see changes in vascular structure in eyes with diabetes without DR. Electrophysiology has shown that even PHNR specifically can be affected even before OCTA changes are seen. So this is another example where multifocal ERG can be affected in patients with DR. And you can see that in patients with non-proliferative diabetic retinopathy itself, so many advanced changes on multifocal DR has been reported. Same way in branch retinal vein occlusion and cases of BRAO, it can very nicely demarcate areas which are affected and which are unaffected. So important thing to remember, multifocal ERG does not replace full field ERG. And before you do multifocal ERG, definitely in the first go, you must do a full field ERG and interpret it with multifocal ERG. And it should not be interpreted in isolation. Topography distribution of the disease is done by the trace arrays and not by the 3D plots alone. These are the few important things to remember where multifocal ERG is concerned. Thank you very much for the patient hearing.
Thank you, Dr. Parveen. Two quick questions. I think one of them you actually answered, but one of the student wants to know status of pupil dilatation for multifocal ERG.
Yeah, so it is done in a pupil in a dilated state. We dilate the pupil and then do multifocal ERG. And we keep the refractive error but in place for the focus, because whenever we do any ERG which has a pattern, whether it is multifocal ERG or pattern ERG or pattern VAP, refractive error correction should always be in place.
The other question which has come up is in which conditions multifocal ERG is absolutely indicated.
So that is the first and foremost thing which comes to the mind is HCQ toxicity, because hydroxychloroquine toxicity is not going to be picked up on any other form of electrophysiological test. And though visual fields has this last paper that I showed by Murmur et al., they have put visual fields and SDOCT. But I would say multifocal ERG scores over visual field because it's an objective test. And you don't need a patient's cooperation for it, and it can show you very early signs. And SDOCT combined with the multifocal ERG forms the standard of HCQ screening.
Can I add one more point, Emma? I
Yes,
have used
please,
multifocal ERG also in before taking up patients of siderosis for surgery. I have had one experience wherein the patient had a good central peak of multifocal ERG and was having a pretty good vision in spite of significant sidrotic changes, and post surgery he suddenly had a drop of vision, and we could document that the central peak on multifocal ERG did suffer the effects of surgery probably. So sidrosis is something in which I'm regularly getting a multifocal ERG done. Your comments on that?
Actually, if what has been documented in literature and what is the understanding also is that sidrosis affects the whole retina, does not affect the macula alone. And sidrosis will cause you decrease in full field ERG itself. And I think the reason why your patient had a maintained peak is that the patients, very much like retinitis pigmentosa, can have a 6/6 vision in sidrosis in spite of a much large area of toxicity already happening. And the loss in the foveal peak may not be due to the surgery, but because sidrosis can progress even after removal of the intraocular foreign body. So this could probably explain. I would say that you are doing multifocal ERG is good, but please do full field ERG also. I'm sure you'll find that also equally.
I was going to ask you whether you did the multifocal ERG because the full field ERG showed a massive.
I could not explain his 6/6, 6/9 vision with such bad full field ERGs and visual field changes.
Exactly. Yes.
And I wanted to document where is he actually seeing from pre-surgery, and then post-surgery, the drop in vision. So
which is why I compared it with retinitis pigmentosa. You will have extinguished ERG, but patients still may have 6/6 vision. So very much the like sidrosis, you may similar kind of thing. And for progression of disease, you will need a multifocal ERG because that's the only way you can measure the small response which is there from the macula.
I think that's excellent, Ritesh. I'm not sure whether in the literature there's much work done on multifocal ERG in sidrosis. So it would be nice to collect all the case series. And if you also have, the SDOCT of these patients to show like how does the sidrosis really progress from the periphery to involve the macular cells. You have, a field or a fundus photo, or all the data of these patients. I think it would make a very good publication for us to know what happens and what are the timelines and what type of patients, because there are patients who don't lose vision. There are patients who lose vision. Most of it has been based on the flash ERG, but I think it will be very interesting to see what is happening through the multifocal ERG.
Sure. Thank you. That was a nice suggestion. Shall we move ahead with the next talk? I think we're just 15 minutes more to the session.
Okay, so I will be now talking about the clinical interpretation and some variations. So we have talked about various tests, but in the clinic, how do we interpret and how do we, answer the question that we are trying to ask after doing this test? So everybody has to remember, as we said, the pearl, that it's the photoreceptor which will pick up the signal and generate the signal, and then it will proceed to the other pathways. And of course, the EOG, that is from the retinal pigment epithelium, will also have the changes based on the response of the photoreceptor. So this we should remember. If we remember this, then our interpretation is very easy. Or what is happening, like the A wave is coming from the photoreceptor, B wave is coming from inner retina, ganglion cells are telling us from the pattern ERG N95, the macular photoreceptors from P50. So it's a very mathematical thing for us to see. Now, the causes of variation, before you answer whether this is pathological or not, could be physiological, technical, and actual pathology. So there are various things which affect the flash ERG and all other electrophysiology. And we are recording, we should record all these parameters also side by side. For example, in newborns, it will be a very immature ERG. So if you don't get an ERG in a newborn, it doesn't mean the child has a retinal dystrophy. So then we should wait, and after 6 to 12 months only, we should check. Same thing for the VP. So if you get a good VP, it's a good story. But if you don't get a VP, it doesn't mean child is going to be blind. It should be repeated again, because these tests take time to mature. So you can see here that, in an adult and in a young person with age, these ERG responses can reduce by some amount. Same way for gender, the smaller eyes of the women. So they have larger ERG than the same refractive error ERG for the males. Then refractive error has a profound effect on ERG. So I have seen patients of high myopia being labeled as retinal dystrophy, whereas that is only a natural low ERG in high myopes. So there are very few studies done on hyperopes and ERG. There are a huge amount of data on myopia and ERG. And this is one study which showed that as the refractive error changes, there is a change in the amplitude of the responses. So when we are interpreting the responses, we should know what was the refractive error of the patient. There is a test-retest variability. So if you do the same test again, there can be 25 to 50% change in the response. Fortunately, whenever there's a pathology, the response change is huge. So if the normal is 300, the disease will not cause 250 or 260. It will cause like 40 or 50. So the range of the disease is very high. So that is why ERG is a very robust test, because the changes are quite huge whenever there is a pathology. Small changes we should ignore because they can just be test-retest variability. Then there's a diurnal variation. So it is known that if you do ERG in the morning versus evening, the photoreceptor shedding is different in the night and in the morning. So if you're doing a research study, then try to do the repeat ERG at the same time. If you're not doing a research study, it's a clinical work, it will not make too much of a difference. But yes, there is some 13 to 15% reduction of the B wave in the afternoon and evening as compared to the early morning. This happens to the visual acuity also. Visual acuity also has a diurnal variation. Then pupil size and media clarity. Definitely, if there's a hard cataract or a corneal opacity or non-dilating pupil or vitreous hemorrhage, then you can get an unrecordable VP and ERG. So remember, for silicone oil, because we do have people who do ERG to find out, should I remove the oil and the cataract, will he get vision? No, the oil has a poor conductivity. So you don't do ERG in a silicone oil filled eye. It will not give you the correct interpretation. Then the pigmentation of the fundus makes a difference. If you have an albinotic eye or a lightly colored fundus, then they will have higher amplitudes than if you have a dark colored, like in South India, then you will have lower amplitudes. Then the dark adaptation state. So the ICEV requires us to do 20 to 30 minutes of dark adaptation, and don't do fundus photography or FFA before ERG, because then you have to dark adapt for more than 1 hour. But if you reduce your dark adaptation time and don't give enough dark adaptation, then you can get a falsely low amplitudes. Then this is important from our point of view. If the patient is on any medication, especially they're taking steroids or quinine or digoxin or certain Dimox, then it can affect. Same thing happens with the alcohol. If somebody takes alcohol, that changes the milieu of the retina, the electrophysiology of the retina, and so you can get a change in the responses. So these are some of the physiological variations. Now, technical causes, of course, if the electrodes are not properly placed, if the stimulus parameters are not normal. Here I'm showing a blink artifact. So why it is blink artifact? Because after repeating the test 2 times, these responses are not the same. And second, there is no response in the eye which comes after 100 milliseconds. Most of the responses will come at a given time. And when there's a disease, it will increase by 5 to 10 milliseconds. It will not go like beyond 150 milliseconds. So these are artifacts because they are beyond the normal physiological timing, and also they are not reproducible. So this is just to show, like, if you have contact lens electrodes, you will get higher responses. If you have Zari electrode or fiber electrodes, then you will have lower responses. The more closer the contact lens is to the cornea, the higher responses you will get. Then it also depends on what stimulus machine was used. So different standards have been given of which type of machine to be used and what type of response you will get. We talked of sidrosis. So yes, if the disease is very early, so here is the early sidrosis, very localized, you will still get very nice responses. You have very advanced sidrosis, you will get a flat response. So again here, this 2 times the test has been done in the left eye. Both times it is flat, but the second time it showed a huge response. Again, this is a blink artifact. This is not a true response. The actual response is here at the beginning of the stimulus. So this is advanced sidrosis, this is early sidrosis. So here's a patient, then it can also affect your response will depend on what was the timeline at which you did the test. So in RP and all, we saw if you do in early phase of the disease or you do in late phase of disease. But here's a medical student who tried to take a high dose of quinine for suicide. You can see her vision was PLPR initially, and we did the electrophysiology. It was showing some responses. The flash VP was absent. There was some ERG coming. And with time, she developed, disc pallor, complete attenuation of vessels. But after 2 weeks, the responses changed. They became very subdued. And at 3 months, there was partial recovery. So if we were not aware of how the quinine will affect the retina in different time points, we would make a mistake of knowing what is happening to this patient. Ultimately, she got 20/25 vision back from PLPR, but she had a very severely constricted field. When you get a flash ERG, there are only this type of reports which you get. It would be either rod cone, which means rod responses are affected more than cones, or cones are affected more than rod, or you get extinguished. Extinguished means there is no response. Or you get a negative ERG, as I said, that means the photoreceptors outer retina is healthy, it's the inner retina which is affected. Or you can get a purely rod abnormal, where all the cone and other responses are normal, or cone abnormal. Very rarely you have something which is mixed up. So it is very easy mathematically to derive that where is the lesion and what is happening to the ERG. So we also said that don't do one test alone. You can, in this diagram, which is available on the net, you can start anywhere. If you want to start, let's say, on a pattern VP, you can start on pattern VP, and if it is abnormal, then go ahead and do a pattern ERG to show that the macula was normal. So depending on type of question that you want to answer, you don't have to do all the tests, but you should know what you are trying to look for and then go backward and do that part of the limb. So that is how you can know whether it's a generalized disease, it's a macular disease, it's an optic nerve disease, it's a maculopathy, or it is a malingering patient. So just to show here, so this is what we typically call as a Cornrod dystrophy. That is, the rod responses are good, the cone responses are absent. This happens in cone diseases, and they always get these blink artifacts. You can see here the cone responses, photopic responses are bad, the scotopic responses are good. So this will be a Cornrod ERG. So we should only tell about the ERG. We should not tell what it is. What it is will be depending on the clinical condition. So here we have good scotopic responses, bad photopic response. The fundus looks normal. So this is a generalized cone dystrophy. Here the fundus is normal except for the macular lesion. The macular responses are bad. The rest of the responses are normal, the photopic responses. So this is only a macular cone dystrophy. Rest of the cones in the retina are healthy. So here we have a patient who has absent cone responses, a near normal looking retina, absent pattern ERG, and a normal rod responses. So this is a rod monochromat. And as I told yesterday, we don't comment on the pattern ERG because they will have good vision. Usually they have 2200 or 2150 vision, but they have nystagmus. So the pattern ERG is not recordable in these eyes. But they have rod cells there and cones are not functioning. They have cones, but they are non-functional cones. So here to show typical vitamin A deficiency ERGs, they have absent rod responses because the rhodopsin is the one which is affected. So this is an alcoholic patient. He complains of night blindness. The top panel shows the ERG when he presented. You can see there is no rod response. The maximal retinal response is bad. But the cone responses are pretty good. That means that the cone photoreceptors generalized are healthy. The rods are abnormal. So it is a rod ERG or a rod abnormal ERG. And after giving injectable vitamin A, you can see the rod responses came back very well. And the oscillatory potentials came back. And of course, the flicker was normal. In very advanced vitamin A deficiency, even the cone responses will get affected. But there you will get the history that nyctalopia was very long standing. So negative ERG, I already told that you will have an A wave and an absent B wave. So immediately you think it's an inner retinal disease, and then seeing the patient, you can find out why it is negative. Now here we have a patient who has retinitis pigmentosa. His flash ERG is abnormal, but his visual acuity is different in two eyes. It is 2200 in right eye and 2020 in the other eye. So if we thought that it is the RP which is causing the loss of vision, but you see the multifocal ERG is normal. That means his macula is really healthy. So actually this patient has suffered a non-anterior ischemic optic neuropathy. You can see his multifocal ERG is good. So that means that this RP patient has actually suffered a artery, optic nerve disorder and not a macular disease, which is what is expected in most of the RP patients with vision loss. So that is how these electrophysiology tests, different tests can tell us where the lesion is in a given patient with multiple diseases in the same eye. So the other tests which we do like pattern ERG, if we do the test very fast, if the checkerboard pattern is rapidly reversing, then we will get something called as a steady state pattern ERG. The normal pattern ERG looks like this. When you do fast, then all the responses become coalescent and you will get something different. So when you're doing the test, the machines, current machines, they are set to certain standards. But if you're trying to do some research, you can change those standards and then you will get something else. Same thing for VP. If VP, you are doing, you have to set the parameters. If you change the parameters, then it will show a difference. Like if you do it for different check sizes or different contrast, then you will get differences. And I think Virendra told about this, that for different check sizes, you will get different responses. And if you do it very fast checkerboard, then again, you will get a steady state VP. That means that the responses are coming too fast and all the responses will get, added up. So to conclude, the variations which happen can be due to physiological, technical, and pathological factors. So always interpret first with the quality of the ERG and the electrophysiology, and then you look at the measurements. It is completely a mathematical science, and you can easily interpret these waveforms without any difficulty. If you know what is the structure of the retina, what is the functional drive of each signal, then you can, report them very easily. There is no difficulty in the reporting of these. It may look very complicated, but actually it's very simple and mathematical. So, the language you speak depends on the region you come from. I'm sure if you say, hot spice girl somewhere, you are thinking of something, but when you come to Andhra, this is our hot spice girl. So always learn the basics and the regional things, and then you can interpret them and get the correct answers. Thank you.
Rolika, do we have time for quiz? It's just 2 minutes left.
Yeah, we'll go quickly over the quiz.
Yeah,
we can
I
just
think
extend for
Dr.
another
Soni
5 to 7 minutes. Yeah.
Yeah, Dr. Soni is there, who is.
Yeah, let's try out some questions.
It'll also be quite a revision also, ma'am.
Yeah. So Deepika is trying to.
Please.
So Soni, you can start answering some of the things, and we'll just go to some of the questions. Deepika, go ahead.
Yeah. Thank you, everyone. I'll quickly start with the quiz. So this is the typical cases we have put. Mainly, we'll focus on the electrophysiology aspect. So here is the first case, RP with macular involvement, 30-year-old male with visual acuity of 20/50, only central 10 degree of visual field is left, night blindness since childhood. typical fundus photo of RP with peripheral bony spicules, macular involvement as well with pigments and atrophy. So this is the ERG. So let us see what pattern ERG and also the full field responses show. If Dr. Soni can take up this question and try to answer what we are seeing here.
Ma'am, both the scotopic and the light adapted phase show both rod and cone responses extinguished, ma'am. And there are no oscillatory potentials also. And
yes, very good. Can you also comment on the pattern ERG box over here?
It is not showing any response from rods and cones.
Yeah, so that means the pattern ERG, it is not showing the response from the macular photoreceptors, that is cones.
Yes.
Okay, so as you rightly said, there is extinguished photopic as well as scotopic responses, and we are seeing over here that the pattern ERG is also extinguished. So this indicates that in this patient of RP, both photoreceptors of periphery as well as central cones are involved. So here the full field ERG along with pattern ERG is giving this message. If the patient had only peripheral involvement and macula was spared, we could have seen some waveforms in the pattern ERG. Okay, so here's a patient of Cornrod Dystrophy, 47-year-old female, defective vision 15 years, visual acuity is 2400, colorblind, and also always had central scotoma. If anyone else or Dr. Soni, can you just look up at these responses, pattern ERG, and these are the full field ERG parameters.
Ma'am, the pattern ERG is showing no cone response, macular responses are not there, and in scotopic and photopic, both the cone responses are
yes, you're right that in the single flash cone and also the flicker, we are not seeing any response.
Yes.
Can you see which artifact is this?
Blink artifact.
Very good, excellent. And in these responses, what they are showing, these are called isolated rod response or maximal combined response. In this, we are able to see some waveforms. Okay, so these are mainly scotopic. So rods are less affected when cones, or in turn, cones are more affected. That's why even the macular cone and also the full field cone are affected. Thereby, it is giving us a more conclusive diagnosis of Cornrod dystrophy. Okay. The next case from points to retain from what we learned over here is full field ERG along with the pattern ERG or multifocal ERG will differentiate the pan-retinal dysfunction versus macular dysfunction. Dr. Ritesh, let me know when I should stop. I'll quickly move to the cases. I just have a few more cases.
You are muted, Ritesh. Okay, go ahead, Deepika.
Good. Okay, thank you.
You have a few more minutes, you can carry on.
Okay, thank you. So this is the patient over here who is a 28-year-old male, family history of some retinal problem in his mother and also in few other family members. Comes with visual acuity of 20/25. Fundus, we are seeing that there is subretinal yellow deposit and also yellow demarcation line, subretinal fluid. Autofluorescence is clearly showing the demarcation in the pathology. OCT is showing subretinal fluid with elongated photoreceptors and some central loss of photoreceptors. So, Dr. Sohani, that my question to you here is, will you treat this patient with any intravitreal injection, or do you want to go ahead with any other investigation to confirm any other diagnosis?
We have to do other investigations for confirmation of diagnosis. No?
Yes, very good. So, which investigations you would like to prefer?
ERG to know the vascular.
Okay, any other?
And FFA, ma'am.
Okay, fine. I'll go ahead with what investigation we have to be proceeding. So this patient is in the stage of Best disease, okay, mostly the stage 3 of the Best disease. So this is the subretinal fluid which will be seen in the patient of Best disease, and it is not due to the any other CNVM variety of kind where intravitreal anti-VEGFs will help. So we have to do both EOG and ERG, as you said. Okay. So EOG, will you be able to try out some points over here in the EOG?
Yes, ma'am. The Ardence ratio is higher, ma'am. The dark trough,
Yes,
the
the dark trough and the light peak.
Light peak by dark trough is increased, ma'am.
What is normal? What is normal?
Normal.
1.8, 1.65 to 1.8.
Yeah.
Yes, you are right. So, okay, in another way, it will be 180% something. So, can you see the Ardent ratio over here? It is less than what we are saying it as normal reference,
Okay.
right?
Okay.
Yeah. So, in this case, the EOG report is reliable, and we do have a reduced Ardence ratio with no light peak or dark trough. But if we see over here, we have good responses in the full field ERG as well as pattern ERG also. We are able to see the P waveform. So this confirms that this is related to the BEST, where only EOG abnormalities will be there. So from
Deepika,
this
can
case,
you go back to the
yes,
fundus
yes.
photo just once?
Yes.
So this is for all the PGs. Whenever you have, because this case can come as a short case in your exam. So whenever you have a patient who has large macular lesions and very abnormal macular lesions or very abnormal OCT, but the visual acuity is extremely good. You can see here, if you had, then you should think of BEST. That is the main diagnosis. The differential diagnosis could be CNVM, AMD, or a toxoplasma, or some retinitis. See, in those patients, visual acuity will be very down. It will be 660 or something. Whenever you have something like a very good visual acuity and the OCT is not matching that, then the first diagnosis is BEST. That is the clue. And go to the next. And you can see here why this patient has good vision, because his pattern ERG is very good. So that fluid which you're seeing on OCT is not actually a fluid where you have to do an FFA and find out the CNVM. This is actually the deposits, the lipofuscin deposits, which are giving that appearance of a fluid. And people I have seen injecting these eyes thinking that there is a CNVM and fluid. So this is where the importance of electrophysiology or just a proper clinical understanding of the disease is there, that the photoreceptors are healthy. It is a RP disease. The photoreceptors are healthy. That is why the macular pattern ERG is completely normal. That's why his visual acuity is very good. In the very late stage of BEST disease, when scarring happens, then the macular photoreceptors start getting affected and you will get abnormal pattern ERG, whereas the full-field ERG will still be normal. And of course, the EOG is always abnormal, even in patients who have a normal-looking retina, like the parents of the child. Even if they are not clinically affected, the EOG will be affected. So this is very important to understand in the BEST disease context. They can get CNVM. If they get CNVM, OCT angio is a very good test to detect that, because the other tests will not show it up. They will get confused with the other findings in BEST disease because the lesions will stain and it will look like if you do FFA in a normal BEST, you will think there's a leak because this lipofuscin will take up staining and you will mistake it for CNVM. So we have published on OCT angio in BEST. Look up that article. Okay, next.
Thank you, Dr. C. That's what you had highlighted. Just I have written in the same points. So I'll skip this. Next case is a HCQ toxicity case. We have recently covered, well covered by Dr. Sen. So I'll just skip it. So just the points to retain from the HCQ toxicity is that whatever we saw in the usefulness of multifocal ERG, the goal of HCQ toxicity screening is to detect early with combination of tests. And we have to prevent from happening these kind of side effects where patients will come with advanced loss of vision. And as Dr. Sen also highlighted, that it will not be reversible even after the stoppage of drug. And as it was highlighted again, very early cases with clinically non-apparent defects can be picked up in a very good way by multifocal ERG. So I'll just ischemic and the non-ischemic part is also covered by Dr. Subhadra. So here the point was that the pattern ERG along with the flash ERG will help in differentiating ischemic and non-ischemic CRVO. So the points in flash ERG which we have to note down is the oscillatory potential, the B waves, and also the flicker, delayed flicker. This was okay, Dr. Sohani, you can just try this out. This was a patient, 18-year-old male with optic disc failure. Ethambutol drug history is there. Can you interpret the VEP followed by pattern ERG and full field ERG?
Ma'am, the pattern ERG showing good response, showing the macula is fine, and visual VEP is showing less responses in both the eyes, and rod response is good.
Yeah, right. So let me help out. The full field ERG is good in a way. As you rightly said, the VP is VP is affected. In the pattern ERG, one point you said that is right, that we are able to see the P50 form. But if you see the N95 wave, we are not seeing that negative waveform which was supposed to be there. This also, the pattern ERG P versus N will differentiate the ganglion cells from the macular photoreceptors. So here N95 is affected, so it is showing that ganglion cells are affected. Again, the VP is affected. Again, it is clear cut that the ganglion cells are affected. So that's how it helps in localization of the cells which is affected. Thanks, Sohani.
Yes.
So this is what the point is. VP along with pattern ERG is useful to differentiate between macular to the optic nerve dysfunction. VP pattern ERG along with full field ERG is useful to differentiate between macular to the optic nerve dysfunction and also panretinal dysfunction. So before I end, I have this master table for electrophysiological test. I thank Dr. Subhadra for this wonderful table which has been designed with a lot of studies before. So this is how we have to perform, and no doubt that electrophysiological tests will help in not only identifying the common diseases, and whenever there is a dilemma case in OPD, and most useful test is the combination of electrophysiological test which we have to do. So I'll just quickly run through this table for easy remembrance. In case of inherited retinal dystrophies, the preferred test will be depending on the clinical picture and other multimodal imaging abilities. So it is EOG, ERG, the bright flash ERG, pattern of multifocal ERGs are useful. In the vascular diseases as well highlighted, ERG, then pattern or multifocal ERG to know the amount of ischemia and also the macular function. In cases of opaque media or trauma, full field ERG along with bright flash ERG, flash VAP will help us. Retrobulbar neuritis, as shown by the case also, pattern or multifocal ERG and pattern VAP will help us. In unexplained visual loss, we saw one more case also, ERG, bright flash ERG, pattern or multifocal ERG and pattern VAP. An infant with questionable vision loss, ERG, flash VAP and sometimes special VAPs. In a case of child with albinism, ERG and special VAPs. Toxic and nutritional eye diseases, EOG, ERG, pattern or multifocal ERG and flash VAP would help us. In inflammatory pathologies, EOG and ERG depending on the type of infection and also the cells where the most of them are infected. Pattern or multifocal ERG will help in the macular diseases. Suspected intracranial lesion, pattern of multifocal ERG and pattern VAP and special VAPs. And in few of these conditions, HVF is also a good reliable test which one has to perform. Thank you everyone. I have these things for today. I request any other comments by Dr. Sen or Dr. Jalal.
Thank you, Dr. Deepika. That was quite a nice revision of most of the things that we have had in the previous two lectures. Thank you so much. And thank you, Dr. Soni, for such an active participation. I think we have...
Dinesh, anything in the end you want to say?
I think it was wonderful. Hearing you was really great, actually. I enjoyed it. And I think this, the quiz is a great idea, but I'm only wondering why only Soni is there.
So we had
this... I must thank Soni for her active participation always. Not just now, in every single session, she's always actively participating and being there.
And I think multifocal ERG is something that, I mean, we covered it very well, and I think we all need to be aware of that. I think one good thing where we sometimes miss that is we end up doing the multifocal ERG, but we must remember to get the normal ERG done, specifically when we are thinking in terms of a global disease. Then I think both are important. I think chloroquine toxicity, maybe we could go ahead with just multifocal ERG as a routine this thing, unless we have a problem there.
So that also, Dr. Dinesh, I would say I had a patient of SLE who had renal disease. So there was a subnormal fulfilled ERG as well. So I think first go when you start the following. First go definitely do a fulfill. Subsequently, probably you can just do a multiple.
It's a good
exercise to have a baseline.
Yes. So I think this is a topic which is actually ignored by most of us. So we have I think the best of the best over here for this topic, and though I got busy somewhere else, I said I must attend. It's a lot to learn here. So it was also a revision for everything, also a learning, and I think it was a great session. Thank you, Subhadra. Thank you, Praveen.
Thank you to iFocus for giving us this opportunity.
Yes,
we also, refreshed our slides, and we also sort of refreshed the
doesn't stay for long. You always have to refresh. So even we have to read. So if you think that you don't remember, it is not correct. Every time we also have to read, and I'm very happy to see young people also being very enthusiastic. Deepika has been really nice. Yes, last time's lecture was very good.
Different to ensure that we don't miss out. And Ritesh does that for me. I use his services to keep on reminding me of what is to be done. So, and thank you, Ritesh, for being there and moderating the session.
Thank you, sir.
Thank you so much.
So everybody who has access to electrophysiology, please go and get your ERG and VP and multifocal ERG done. And then you will see it's quite simple and you will learn it faster. That's how I started learning.
That's a great.
Definitely, ma'am.
At least those who have these equipments in their centers, there's no point in your going out of your center and never having visited the center lab.
One thing I'd like to point out, and that's one of the things which can make a lot of difference. If your machines are not standardized, a lot of this is a waste.
Yes.
This is one of the biggest problems that comes. People buy the machines, but the machines are not standardized. And if they're not standardized, then actually your results get very badly affected.
Yeah. So every year, the company is supposed to come and do the standardization, just like they do for the visual fields. Yeah. So you must have that in your contract. They come and they do the standardization every year. That is part of the maintenance of the machine. Yeah.
Thank you.
Thank you, ma'am. Thank you so much, everyone, for the session. The next session is going to be on December 22nd. That is putting it all together. Clinical applications of multimodal imaging by Dr. Marco Lupidi. We all will see you there. Thanks a lot, everyone, for being there.
Thank you, ma'am. Bye.
Bye.
Thank you. Bye.
Thank you.